Good afternoon, ladies and gentlemen. I'm Laurent Guyane, the CEO of SENS-111. It's our pleasure to welcome you to this K0L events. So SENS-111 is a biotech specialized in developing new drug treatment for inner ear disorders, vertigo, hearing loss, and tinnitus. We are a publicly traded company in France, Alternext. And basically today we are going to talk about novel approaches to treat acute unilateral vestibulopathy. So I will start with a couple of slides on the company, and then I will hand over to our two speakers of the day, namely Professor Michael Stroop, who is a professor in neurology and working at the Ludwig Maximilian University and German Center for Vertigo in Munich. Professor Stroop has a tremendous experience in ear disorders, namely balance disorders and vertigo. He has extensively published on that topic, and he will cover this topic of novel approach to treat AUV. And then we have the second speaker with Pierre Attali, who is the Chief Medical Officer at SENS-111. And Pierre will present a program, SENS-111, a new H4 receptor antagonist for the treatment of vertigo. A couple of slides on the company. So SENS-111 is a pure player in developing new drugs for the treatment of inner ear disorders, a very attractive market. The company was founded in 2009 as a spin-off of an academic research unit in France, in south of France, in Montpellier, from INSERM. And we since developed this spin-off into a biotech, able to develop drugs according to the pharma standards. The company is developing first-in-class small molecules that are orally active. And the leadership team is made of a blend of people coming from academia and people coming from the pharma industry, the right blend to do the translational work from science to drug development. The company went public in April 2015. And today we have, if you look at our shareholding structure, we have two major shareholders, namely INSERM Transfer Initiative and Innobio BPI France. And the float part is about 42%. We are a small company that is located in south of France in Montpellier, and we operate according to a lean model. Basically, we are 17 people, most of them operating the R&D activity, and we are, as you can imagine, operating an ecosystem of vendors, CROs, and advisors to help us developing our products. So the company itself has two assets. The first one is a screening platform, internal, that is made of various tests, in vitro, ex vivo, in vivo. We can reproduce vertigo and auditory dysfunction in animals. And we are using this platform to select programs. And basically we have three programs that are active in R&D right now. The first program, product SENS-111, which is an H4 antagonist for the treatment of acute vertigo. We have just received FDA clearance to run clinical trials in the US, and that will be the topic of the day. The second program is 401. It's a program that has anti-lesional properties, so basically it's able to protect the inner ear when you have a lesional process ongoing. And we are developing this product in the treatment of sudden sensory neural hearing loss, and we have just received orphan drug designation in Europe for that program that is currently in early clinical development. The third program is SENS-300, and it's dedicated to the treatment or the prevention of drug-induced ototoxicity, namely toxicity related to anti-cancer treatment based on cisplatin. So this is for us a very interesting combination of two assets, since we can continue to explore the screening platform to develop program number 4, program number 5, either alone or in collaboration with an interesting pharma. So on that, I will hand over to Professor Michael Stroop. Michael.
Ladies and gentlemen, colleagues, my part is to enlighten you on the clinical issues of this disease. That means I'm going to describe the entity we are dealing with, so-called acute unilateral vestibulopathy. all the clinical signs. I'm also going to explain you why you feel dizzy if one labyrinth is not working properly. I'm going to present the current treatment and some perspectives. But to give you an idea about the relevance of vertigo and dizziness, I'm going to show you first some numbers, and I would assume that some of you are familiar with looking at numbers. And this is about the relevance of vertigo and dizziness. By the way, who of you ever suffered from vertigo and dizziness? Can you raise your hand? Okay, it's a very healthy population. Anyway, so these data are from the National Health Interview Service, and 214 million Americans were interviewed. And it turned out that over 1 year, 24 million of them complained of clinically relevant vertigo and dizziness. That means 11.1%. Secondly, it's important for you to note that it affects mainly people in the middle age who are professionally and socially very active. That means the impact on your functioning and quality of life can be really tremendous. If you compare the annual incidence with other frequent disorders, you will easily recognize that dizziness is more frequent than cardiovascular diseases, more frequent than even cancer, cerebrovascular diseases, and diabetes mellitus. Finally, if someone is suffering from vertigo and dizziness, this is a substantial risk factors associated with a 1.7 higher mortality, mainly due to falls. And here is what you can expect during the next 15 minutes. I'm going to talk on the history and the terminology of so-called acute unilateral vestibulopathy, which had been previously also called vestibular neuritis. Then I'm giving you some data on the epidemiology, also in relation to other vestibular disorders. I'm going to explain you, as I said before, why you feel dizzy, why you suffer from severe spinning vertigo if one labyrinth is not working properly. Another important aspect is what's going to happen in your brain after such a lesion. How is that so-called centrally compensated? Further, I'd like to demonstrate how to diagnose the disease, what is the spontaneous cause, what's the recurrence rate, and finally, how do we treat currently acute unilateral vestibulopathy. So looking back, the disease was already described in 1908 by an Austrian otorhinolaryngologist, Routine, and he used the term which we often use, Neuritis vestibularis in German. But now, according to the International Classification System of Vestibular Disorders, it's now called acute unilateral vestibulopathy, and this is going to be the term for the future. Here you see the data from our German Dizziness Center in Munich on more than 23,000 patients, and you can easily see that acute unilateral vestibulopathy is after benign paroxysmal positioning vertigo, vestibular and Meniere's disease, and acute unilateral vestibulopathy, the third most frequent type of vertigo. The annual incidence ranges around 10 per 100,000. In our center, we see about 100 to 200 patients per year, which require a treatment. The long-term recovery rate is quite good, but today we are focusing on the short-term treatment of the symptoms, not the long-term outcome. The recurrence rate is between 2 and 10%, and one serious complication is the development of so-called secondary functional dizziness. This in particular occurs if you experience very severe spinning vertigo, and this is something we can reduce with the drug we are going to talk about. Listen to the patient, please. What brought you to us today?
I came because of a very strong nausea and strong dizziness.
Did it begin suddenly or develop slowly?
It began suddenly.
And how many days ago was that?
That was on Wednesday at 7 p.m. 2 days ago.
When the dizziness occurred, did you have a tendency to fall to one side or unsteadiness of gait?
I felt very, very nauseous, and an unsteadiness came, and it turned me slightly to the left, or more like it shoved me.
So this is a typical history, acute onset of severe spinning vertigo. Most patients have to rest for several days in bed. They're not able to walk. And here you see the clinical findings. If the patient is able to fixate, there's nothing you can see. But if you prevent visual fixation, you see these eye movements. They're called nystagmus. This is a Greek term. And you see the eyes, the quick phase to the right and the slow phase to the left. And that's a typical clinical finding of acute unilateral vestibulopathy. The diagnosis can be easily made by a simple test. Can you come to the podium? Take off your glasses. Okay. So you can put on these glasses with all modesty. They are called Michael's glasses. And then you can prevent visual fixation suppression of such a nystagmus. So for the doctors, it's easy. And there is another test which is called head impulse test. Can you fixate my nose? Hold your head very tight. It's going to be a rough test. I have to warn you. And then you make a very quick turn in one direction and in the other direction. And that's the way to diagnose acute unilateral vestibulopathy. Thank you very much for your cooperation. So it takes about 5 minutes till the diagnosis is made. And here you can see a typical finding. When the head is turned to the left, the eyes move with the patient's head to the left, and then the patient has to make a refixation saccade. This indicates a deficit of the vestibular system on the left side. And what is also very prominent is postural sway. You see, with the eyes closed, this subject is not able to stand. And this is something we have to treat. Another typical symptom patients have with an acute unilateral vestibulopathy is blurred vision. It's so-called oscillopsia. And that's easy for you to simulate. Can you cover one eye, please, everybody? And now press with the tip of the index finger on the lower eyelid of the other eye, and thereby on the eye bulb, with a frequency of 2 to 3 hertz. What do you see? What's happening? The image is jumping. Do you like that? No. If you do that for a longer time, you will also develop nausea and even vomiting. And here you see a video which was taken with a particular camera which allows you to see the world through the patient's eyes. It's called the IC cam. It's not an iPad or an iPod, but it's an IC cam. And that's the way patients with this disease perceive their visual environment. And all these symptoms have to be treated. Here again, the summary. So patients have this typical nystagmus, a pathological head impulse test, and a so-called nystagmus. All these signs and symptoms can be simulated in an animal model, which we have established. That means you simply surgically destroy one labyrinth, and if you do so, you will see findings like that. So this animal, this rat, spins around, and this lasts for about 4 or 5 days. And these models are ideal also to evaluate whether a drug is effective or not. And that's a reasonable approach, and you will see some data on that later. So the question arises, why do you feel dizzy if one labyrinth is not working properly? While you are sitting here, you receive, believe it or not, 1.8 million action potentials per second from your right and from your left labyrinth. So that's quite a lot. But since this is identical from the right and the left, you don't feel dizzy. Now imagine that one labyrinth is not working properly, and then you get a so-called vestibular tone imbalance. So 1.8 million versus theoretically 0. And this leads to severe spinning vertigo, to a nystagmus, to postural imbalance, nausea, and vomiting. And this is so-called centrally compensated, this vestibular tone imbalance. And many parts of the brain are involved in this central compensation. But first, there is a so-called decompensation. Due to central mechanisms, for the first few hours, the symptoms become even stronger. This is called vestibular decompensation. And then other parts of the brain are involved, the neurons by itself, the spinal cord with increased sensory input, and finally the cerebellum, which suppresses this vestibular tone imbalance. Next part is going to deal with the treatment. How do you treat these patients? Basically, you have three options: treatment of symptoms, treatment of the underlying cause, and vestibular exercises to improve this central vestibular compensation. And this is an area with a high medical need: symptomatic treatment. The drugs which have been used over the last 50 years, they're all sedatives. They make you tired. If you're tired, you do not move, you don't do any vestibular exercises, and they suppress the symptoms, but the major side effect is suppression of the vestibular system, like dimenhydrinate or benzodiazepines. So clinically, there's a very strong need for drugs which are non-sedatives to treat these patients. Second part, how do you treat the disease by itself? We have done a lot of molecular biology studies over the last years, and we found good evidence that this disease, which was previously called vestibular neuritis, is caused by the reactivation of a latent herpes simplex virus 1 infection. Herpes simplex causes these blisters. Have you ever had these blisters? In Paris, none of them this morning, but here in England it's evidently more frequent. So these are the same viruses. And based on this idea, we published in 2004 this paper in the New England Journal of Medicine. We had 4 groups: placebo, steroids, an antiviral agent, and the combination of both. And contrary to our assumption, a therapy with steroids only is sufficient. And the third column of treatment is vestibular exercises. Already in 1998, we published this study. Patient here, we measured postural sway. Here the sway in the control group, and this is the sway in the group of patients who received 30 minutes, 3 times per day vestibular exercises. You see the sway is much lower. So to summarize the aspects, vertigo and dizziness are very frequent symptoms. One of the most frequent types is acute unilateral vestibulopathy. And when it comes to the treatment, there's an urgent need for a symptomatic treatment with drugs which are no sedatives. What are the perspectives? Acute unilateral vestibulopathy is assumed to be an ideal model for vestibular diseases. And if this trial shows a benefit of any agent, the drug is also going to be used in other diseases which lead to dizziness, to vertigo. In particular, patients who have a stroke in the brainstem or the cerebellum, they have the same symptoms and they need a treatment. The same is true for patients with Meniere's disease or vestibular migraine. These are diseases which are characterized by attacks of vertigo lasting many hours, even up to 3 days, with severe vertigo, nausea, vomiting, and they also need a symptomatic treatment to reduce the symptoms. And it can finally also be used as a symptomatic treatment for patients who have a so-called benign paroxysmal positioning vertigo during the treatment. So all in all, there's a wide spectrum of indications for such a non-sedative drug. Thank you very much for your attention. So are there any questions in the audience on the clinical aspects of the disease? Yes, sir.
You didn't really cover what was triggering the disease at the outset. I mean, you talked about things like HSV.
Yes.
But what's triggering the biology to...
Okay. In most patients, it occurs out of the blue. So we don't know what's behind this. But what has been shown is that it's more frequent during spring and late summertime. This is the time when many patients have some allergic reactions, some autoimmune processes occur, but in most patients it occurs can happen to you next moment, and we don't know why. The same is true with herpes. You know, it occurs sometimes when you have stress or sun. Yes, normally there's a balance between the replication of this virus and the immune system. You can demonstrate that. And if this balance is lost, the virus replicates, the nerve swells, and this leads to the damage. Further questions? Yes, sir. Yeah, best you take the microphone for
Okay,
the
sure.
transfer.
I mean, does it? Well, I was trying to understand whether it resolves normally. I mean, is the standard approach is to try to, accelerate a normal resolution that would occur anyway in those patients. Is that
Okay.
true?
Yeah. So we have two aspects in terms of the treatment. The first one is the symptomatic treatment, and this is what we are dealing with today. The other aspect is the long-term outcome. And in the long-term outcome, 60% of the patients recover. But this is not related to the symptomatic treated in the early phase. So what we are dealing with today is treatment of the acute symptoms over the first 5 to 7 days. Because then the patients are not able to walk, not able to get up, not able to go to work. And here we need a drug to accelerate the improvement of symptoms. This will not have an impact on the long-term outcome.
Okay. And I presume that the patients must have multiple attacks. I mean, before they would get referred to a sort of expert centre like yours, I imagine, they must just think they were unwell and go to bed and so on.
Well, most patients, they come to hospital, and we just finalized another trial, so we had no issues with the recruitment of the patients. So they come to the centres, and then they are seen within 1 or 2 days, which is sufficient to be included into this trial.
And that could be their first attack. I mean,
Yeah.
I'm just wondering if the patients have these things frequently or...
No, most often they have it just once. But if you look at the other diseases, there they have frequent attacks. For instance, in Meniere's disease, there are patients who have every second day an attack, and then they need a symptomatic treatment. And once again, acute unilateral vestibulopathy is an ideal model to look if a drug has a benefit in this area or not.
Thank you.
Yes, sir?
Just a quick question.
Yeah.
How long does the conditioning therapy take to have an effect on a patient, and how many days and how long is each session?
What do you mean by
You
conditioning?
said, sorry, there are 3 treatments.
Okay, the first one is a symptomatic treatment. Normally patients are treated for about 5 days, and then the acute phase is over. Steroids we have given for 4 weeks to improve the recovery. Vestibular exercises also for 4 weeks. So it's a short-term treatment, about 5 days.
And for the long-term therapy, the final one, how long is that each session that they have to go through to retrain
You talk about vestibular exercise, 30 minutes. 30 minutes 3 times
in
per
a
day.
specialist centre?
No, this is, day 1 to day 3 in a specialized center, but later on they get written instructions and then they can do it after 1 week at home by themselves.
Okay.
Further questions, gentlemen? Yeah, there's another one here.
I wonder what your thoughts is in terms of the rationale for the mechanism that is being pursued by Sensorion, the H4R antagonist approach.
So as will be demonstrated in a few moments, these receptors are expressed on specific so-called vestibular ganglion cells, and they are responsible for the tonic activity of the vestibular nerve. And if you suppress that, you reduce the so-called vestibular tone imbalance. That means these drugs act on a very basic mechanism to suppress the vestibular tone imbalance. And they do not interfere with central compensation, and that's a major advantage because it's so specific, the H4 receptor. But Pierre is going to describe that in detail. Any further questions? Yes, sir.
I mean, do you think that HSV is the only
No.
causative agent in
No,
this?
we don't know. And therefore, we changed the terminology. So previously it was vestibular neuritis. Now it's called acute unilateral vestibulopathy because we do not exactly know what's happening in all patients. Maybe a part of them is related to HSV, but this has no impact on the symptomatic treatment.
Right. I'm just wondering why your study where you had used anti-HSV drugs, ganciclovir and so forth,
Why-
was not actually successful.
Oh, that's a good question. The reviewers also asked this question. Well, the point is, if the symptoms start, the replication of the virus is already finished. So we are just too late. That's the point. And the same is true for the prognosis of herpes simplex encephalitis. If you start too late, the prognosis will be bad. So we start just too late with the antiviral agents. That means if a patient comes in the very acute phase, you might have a benefit with the drug. But in this study, patients were recluded within the first 3 days. Very good questions. I'm impressed. Thank you. Okay, if there are no further questions, thank you very much again for your attention. Bye. Okay. Good afternoon. Is the microphone on? Okay, thanks. So we're going to speak on SENS-111, and as Michael told you, I mean, when you have an acute unilateral vestibulopathy, you have an imbalance between the two vestibules, and this results in vertigo. Okay, and normally after 21, 30 days, there is some restoration of the vestibular function, but there is also a central compensation, and this results in a better balance for patients. Now, during the acute phase, you have a strong imbalance between the two vestibules, which causes the vertigo and nausea and vomiting. And during this period, which could last up to 7 days, usually 3 to 4 days, but up to 7 days, people feel very, very ill. They cannot walk, they cannot drive, they cannot work, they have to be in bed for several days. So the objective of a treatment, symptomatic treatment, is really to treat patients during this period, which is a very acute one, which is just as paracetamol you can do with paracetamol when you have some pain, or paracetamol you have some fever. Just try to reduce the symptoms to have people feeling much better. Now, histamines, as Michael told you, histamines have been used for a long period of time for the treatment of these symptoms, and particularly the H1 antagonists. These drugs are usually poorly effective, but they are strongly sedative, and sedation could impair central compensation, future central compensation. So this is important not to have the sedation for a too long period of time. And so they are used because people feel very bad, but at the end of the day, it's not an ideal treatment. Beta-histine, which is an A3 receptor antagonist, is also used for these patients, but it's poorly effective. So it has been used, and antihistamines are used for the treatment of these symptoms. Now, it has been recently discovered an H4 receptor, and these H4 receptors are expressed in several organs, just as bone marrow, white blood cells, liver, colon, and so on. And they have known, and when you administer an H4 antagonist, you have some immunomodulation, and also you have some anti-inflammatory properties. Now, these receptors are also expressed in inner ear. And as Michael told you, they are expressed in the scarpa ganglion, which is a vestibular ganglion, and they are expressed on the primary neurons, vestibular neurons, and this localization is very different from the localizations of the other receptors. H1 receptors, there are some expression, marked expression in CNS, which is not the case at all with H4 receptor, which are not expressed in CNS. And this is a marked difference with the other treatments. No expression in the CNS, so you could expect almost no CNS effect. So at the end of the day, it shouldn't impact central compensation. It could result in a preservation on the central compensation. Now, H4 antagonists just inhibit the action potential firing, as Michael told you before.
And the effect on this drug of these drugs is very different. You can see on the screen here the effect of H4 receptor antagonist at very low dose, and even at high doses you have an inhibition of the IP firing, action potential firing. When you use betahistine, you have this effect at low dose, but when you increase the dose, then you totally block the effect, the depolarization, and then you suppress the effect. So this localization and this effect on H4 receptor are really important and relevant for the treatment of inner ear disorders. We have on this slide done some experiments in which we have evaluated the effect on different concentrations on the primary or vestibular neurons, and as you can see here, there is a nice concentration-dependent effect on the inhibition of action potential firing on vestibular neurons with an IC50, which is about 30 nanomolar. And we also measured after the administration, the IV administration of SENS-111, we also measure concentrations in plasma, inner ear, and perilymph. Perilymph is a liquid which is in the vestibule, and we measure the concentration in order to see and to evaluate whether we could find this product after a systemic administration in the organ where the symptoms come from. And we were able to demonstrate and to show that there is very high concentrations after the systemic administration, very high concentrations of SENS-111 for at least 5 hours, largely, markedly over the IC50. So it means that the drug is penetrating into the inner ear where the disease is and where the H4 receptors are. Now we also had some in vivo experiments, the same, we are using the same I would say models that the one showed by Michael previously, and the mice, just spinning around. And in this model, we were able to first show that there is a dose-dependent effect. So you can increase the dose, and if you increase the dose, you have about 30% reduction in the spinning vertigo of the rats and of nystagmus. So a 30% improvement. It's rapid, occurring almost 1 hour after it has been administered. So it's really relevant for, once again, for acute disorders, acute inner ear disorders. We tested that as well versus meclizine. Meclizine is an H1 receptor antagonist. We used very high doses of meclizine, and as you can see on this slide, the effect was much more rapid than meclizine, and it was much more potent as well. The maximum effect of meclizine was a reduction of 20% in the spinning behavior and on nystagmus. And what is important to understand is that at this dose, 50 milligrams per kg in the rat, the rats were totally sedated. They were sleeping. I mean, in their boxes. So it's much more rapid, much more potent, and we didn't observe in these experiments any sedation with SENS-111. We did the same experiment using another model, but almost the same, and we tested this drug versus meclizine and versus methylprednisone corticosteroids. And as you can see here, once again, you have almost 30% reduction in nystagmus and rat behavior, and you have a small effect, but an effect of corticosteroids lasting 2 hours, and then it's slowly disappeared. After 3 or 4 hours, no more effect. And when we use meclizine at human equivalent dose, at dose of 5 milligrams per kg, so this is the dose which are used in human, meclizine had no effect at all on nystagmus and vertigo. So clearly, SENS-111 significantly reduced the symptoms related to vestibular dysfunction, and they were much more potent than the drugs that are used currently in the clinic. So just to summarize the preclinical data, first of all, H4 receptor antagonist, H4 receptors are expressed in inner ear. They are localized on primary vestibular neurons at the scapa ganglion. There is no H4 receptor at the central vestibular nuclei, so it's really peripheral, not central. When you administer the H4 receptor antagonist, there is an inhibition of action potential firing without neuronal depolarization. And this effect with a low risk of induces or results in a low risks of CNS depression, which means less sedation, less cognition effect, less cognition impairment, and there is no, theoretically, no impairment of the central compensation, which should occur as it occurs normally. Now, SENS-111 is a potent H4 receptor antagonist. It acts rapidly and dose-dependently, up to 20 milligrams per kg in animal models, and it reduces vestibular dysfunction, and it acts more rapidly and more potently than meclizine without the sedation induced by meclizine. So it is perfectly adapted for the treatment of acute unilateral vestibulopathy or for vestibular disorders. Now, after these preclinical experiments, we have carried out a large phase 1 clinical trial, in which the objectives of which were first to evaluate the safety of drugs as usual, second to evaluate the pharmacokinetic profile as usual, but we also decided to evaluate as a secondary outcome, to evaluate the effect of a routine test, which is a caloric test, and to see what it does in healthy volunteers, and second, to evaluate whether SENS-111 could be able to reduce, to modify the vestibular symptoms induced by the caloric test. We just carried out a phase 1 study, which was a randomized placebo control in almost 100 healthy volunteers, with two parts. Phase 1, first part, which was a single dose study in which we increased the dose to evaluate safety and the pharmacokinetics of this drug. We have evaluated doses up to 500 milligrams. And there was a second part, the part B, in which we carried out the caloric test, where the drug was administered for 4 to 7 days to healthy volunteers, with doses from 50 to 250 milligrams per day. And we used 5 cohorts of 12 healthy volunteers, 9 treated with SENS-111 and 3 treated with placebo. And then we had on this second part, the caloric test. The caloric test is a test which is currently used by the ENT and neurologist for the diagnosis and the evaluation of the vestibular dysfunction in patients. And what we did was to irrigate, to use this test and to modify it slightly, to use this test to evaluate whether we could induce some vertigo. Basically, with this test, we were able to induce a transient vestibular dysfunction, which lasted between 2 to 3 minutes. So it's very short duration of vertigo. And we measured using VAS the duration, the severity, the latency of appearance of disappearance of vertigo, several parameters. We also measured nystagmus. First, safety of this product, very safe, well tolerated. The incidence of adverse events was very low with SENS-111, 16% versus 36% with placebo, so no major effect. And as you can see on the slide, and you have that on your book, no sedation at all, not at all. And we also looked at the biological test, cardiovascular test, nothing, really safe. We have evaluated as well the pharmacokinetic profile of this drug, which is the following. There is a low inter-individual variability. It's, the pharmacokinetic is linear with dose up to 200 milligrams per day. At higher doses, it's slightly over proportional. Third, the elimination half-life is between 24 to 48 hours, which means that it's a single, once daily administration. You don't need to administer it several times a day. And we know that this drug is eliminated mainly through the urine route, and 50% is eliminated unchanged in urine. So a pharmacokinetic profile, once again, adapted to the inner ear disorders. And then the vestibular test, the caloric test. And we, just to let you know, we applied, or we've carried out this vestibular test 3 times in 3 hours apart as a baseline to evaluate how this test was. And then this test was applied every day for 7 days, 2 hours after the administration of drug. And basically there are 2, at baseline we have seen 2 important results. First one, there is a marked intra-individual variability of this test, between 15 to 50%, which means that the test is very variable. Okay? Induced vertigo, which could be modest, which could be more severe, but at the end of the day, if you look at it, and I just show you on this slide 2 examples, if you look at vertigo, the vertigo was very short, about 1.5 minutes as a mean, and it was mild, of mild severity, rated 43 millimeter on the VAS, and 43 millimeter correspond to a mild vertigo, not moderate, not severe, which is higher than 70 or even 80 millimeters. So this is very important to understand. You have a large, marked inter-individual variability, a mild effect, so it's very difficult to evaluate the pharmacodynamic of a drug in this situation. If this is positive, that it means that your drug is very likely to be active, very likely to be active. And this is what we did. We have done pharmacokinetic, pharmacodynamic interactions. We have shown that in the range of dose between, I would say 100 nanogram per ml up to 500 or 700 nanogram per ml, there was a reduction of about 30% of the vertigo that induced by the caloric test in these healthy volunteers. It was exactly the same for the latency of appearance, and all the vertigo parameters were improved between, let's say, 20 to 30%. And I remind you that it's exactly the same percentage of improvement that the improvement that we have seen in the rats. So it's really totally relevant. We haven't observed in the study any effect on nystagmus, but on vertigo it was quite clear, marked effect. Now, just to sum up with the results and the data of this phase 1 study. First, it's well tolerated. Second, the pharmacokinetic is linear with doses up to 200 milligrams per day for several days. So the elimination half-life allows a once daily dosing. Third, the data are totally consistent with what we have seen in preclinical experiments, and this was very useful for us to design the phase 2 trial, which is starting. So what is the phase 2 trial about? The phase 2 trial is to treat the symptoms of acute unilateral vestibulopathy. Why this disease? As Michael told you before, it's a very pure vestibular dysfunction. It's with a sudden occurrence, very severe. It lasts for 4 to 7 days. So it's a pure situation in patients otherwise healthy, usually healthy. No history of hearing loss, no history of previous vestibular diseases. And this leads to a strong imbalance, strong vertigos, and a marked tendency to fall, as shown by Michael. And what is important to understand is, and Michael told you that, but I will tell that in another way, I mean, about 40 to 50% of patients after 1 month, when they had their central compensation, about 40 to 50 patients are still suffering from some dizziness, some imbalance. They are not totally cured. The recovery of the disease is not complete in almost half of the patients, which means that these patients will have impairment, or will have a vestibular impairment for their life. It's a rare disease, and as Michael told you, no treatments right now. So it's a disease without any treatment. This acute phase, we have no effective treatment, and there is a need for clinicians for that. So we are starting phase 2 clinical trial, which is really classical, I would say, randomized, double-blind, placebo-controlled. We will be testing 2 doses, 100 and 200 milligrams per day for 4 days. Importantly, you probably remember that Michael Stroop told you that these patients are suffering from nausea and vomiting. We are using, and we will be using, a specific formulation for these patients, which is an oral dispersible tablet. So they can put the tablet on their tongue. The tablet will dissolve in few seconds. So they could, be treated, and you can be sure that they will not have vomiting and have the drug not working. The primary objective is quite clear: demonstrate the efficacy of this drug, 1 or 2 doses. But we also will try to determine the optimal dose regimen for SENS-111. We will evaluate, of course, safety and tolerability of this SENS-111 drug in these patients. And importantly, we will also evaluate the long-term effect. In other words, we will ensure that we will have a positive effect on central compensation. We believe that having the patients treated rapidly, they could start their vestibular rehabilitation earlier, and then we could improve the long-term effect or the long-term impairment of these patients. We also will explore the effect of this drug on quality of life. We also will look at the plasma exposure, and we'll preliminarily evaluate some the health economic parameters to see if it makes sense. Now, it's an international trial which will be carried out. This is going to be carried out in the US, in Europe, and in Korea. 25 sites have agreed to participate to this trial, and of course, the CRO is already chosen and working on that. We are not big enough to have our own, let's say, monitors. It's an oral dispersible tablet which will be tested, as I told you, 2 doses, 100 and 200 milligrams per day, with a midterm follow-up, 1 month, at 1 month, when the central compensation is maximum. And it's correctly powered, and I would like to insist on that. We have an alpha risk of 5%, beta risk of 85%, and this leads to a number of patients which is more than 200 patients. No clinical trials have been done in a large population right now in this disease, which once again is a rare disease. And the planning, if the trial is longer than 1 year, we will have an interim analysis. And for this interim analysis, we won't do this interim analysis on the primary endpoint in order to preserve the power of the study, but we will do it on the secondary endpoint, and I will show you which endpoint it's going to be. And the planning is to have the first patients included in the next quarter, in 2007, and to complete the trial with the results by the 3rd or 4th quarter of 2018. This is basically the design of the study, very simple, randomization, and then 3 arms, placebo, 100 and 200 milligrams, evaluation every day, twice daily, at 11 a.m. and 5 p.m. because this is the period where the vertigo is the most severe. And we will have evaluation for 5 days, and then at D14 and D28 in order to make sure that everything is going well. Finally, the endpoints. The primary endpoint, which has been validated by the regulatory authorities, is to measure the intensity and the duration of vertigo, and we will use what is called the AUC, the area under the curve, in order to make sure that we measure both intensity and the duration. We will use it we will measure that using a VAS in standing position, which is the worst situation for the patients. And as secondary endpoint, we'll have the worst spontaneous vertigo intensity, which will be used for the interim analysis. And we'll have some more, I would say, objective measurements, such as a Romberg test, the peak slow phase velocity of the nystagmus, and also we will measure nausea and vomiting using VAS, and of course we'll measure the functional disability after treatment using two well-known scales, which is a DHI, dizziness and decap inventory, and the VADL, which is the vestibular disorders activity of daily living scale. We also used other exploratory endpoints, such as the time to unassisted walk. We haven't put that in the secondary endpoint simply because in some countries, such as the US, the patients are not hospitalized for 4 to 5 days, so it will be extremely difficult to evaluate that in the US. In some countries, in Europe, France, Germany, and so on, the patients are hospitalized. In the UK, they are not. So there are some differences in the management of these patients. So this is why it's on other endpoints. As other endpoints, we also will have some health economic parameters evaluation using the work productivity and activity impairment, which is a classical scale for patients with vertigo. Now, just to sum up. This drug is really the first in-class new chemical entity targeting the H4 receptor. It's administered systemically. It's an oral administration. It's a small molecule, which is correctly patented, and the patent should extend up to 2028. And without having I would say, the usual extension, and particularly the 5-year extension. So we have a long time to market this drug as well. It's an attractive drug profile. This drug has an attractive profile with positive preclinical data as compared to the current treatments. With a clinical tolerance which is good, as seen in the 227 healthy volunteers that have been evaluated to date. A pharmacokinetic profile which allows a once daily administration, and some, I would say, strong signals, even more than that, strong signals of efficacy using the caloric test in healthy volunteers. So it's really a drug which should be very active in this disease, and we are currently implementing the centers, and we should have, as I told you before, we should have the first patients included in this trial in the first quarter next year. Thank you very much for your attention.